Hello, and thank you for joining today's webcast, reviewing the current practice of neuromuscular blocking drugs to universal agents dosing, presented by Professor Manfred Blobner. My name is Jonah Atterbury. I'm a physician and the medical director of patient monitoring at GE Healthcare. I'll be facilitating today's webinar. Before we begin, we want to cover a few housekeeping items. At the bottom of your screen are multiple application widgets which you can use. I'll briefly cover the most important ones. During the webcast, please submit questions through the Q&A widget. We will try to answer as many as possible at the end of today's presentation. You can find additional questions to some common technical issues located in the Help widget at the bottom of your screen. For the best viewing experience, we recommend using a wired internet connection and closing any programs running in the background. Lastly, this webinar recording is the exclusive property of GE Healthcare. No part of the following content may be copied or reproduced without prior written permission from GE Healthcare. And with that, I'd like to introduce today's speaker. Professor Manfred Blobner is a professor of anesthesiology and senior consultant and vice director of the Department of Anesthesiology and Intensive Care Medicine, School of Medicine, Technical University of Munich. Over the last 30 years, he inaugurated and chaired 7 clinical and experimental research groups, which became independent under his former assistants and followers, and are still working in their respective fields successfully. He keeps the lead of the research group on neuromuscular physiology and pharmacology. He's the author of more than 152 manuscripts published in international journals. He is also the chief investigator of the European Society of Anesthesiology Clinical Trial Network and a member of ESA's Scientific Subcommittee of Pharmacology. These are Professor Manfred Blobner's conflicts of interest. And with that, I will turn it over to him. Thank you, Dr. Blobner.
Thank you very much, Jonah, for your nice introduction. And thank you very much to GE that GE will help us to give this reviewing the current practice of neuromuscular blocking drugs and reversal aging dosing. I'm very happy to speak about that. Monitoring during anesthesia today is mostly focused on cardiovascular monitoring, respiratory monitoring, and monitoring of the function of the anesthesia machine. But that's not monitoring of anesthesia, it's monitoring during anesthesia. Monitoring of anesthesia would be the direct monitoring of hypnosis, analgesia, and immobility. People may say that this kind of monitoring is most likely too complicated, but actually monitoring of anesthesia is able by processed EEG monitoring, quantitative neuromuscular monitoring, and monitoring of nociception may also be possible indirectly by processing of data evaluated during cardiovascular monitoring. Unfortunately, less than 15% in European patients will really get a monitoring of anesthesia. In particular, quantitative neuromuscular monitoring is not used in a huge majority of patients also receiving neuromuscular blocking agents. Therefore, it is put much hope in the publication of guidelines that most likely will help us to bring neuromuscular monitoring to the patients. ESA and ASA guidelines have been published a little bit more than 1 year ago. And I will focus on the monitoring part of these guidelines, and in particular on avoidance of residual neuromuscular block by using neuromuscular monitoring. I have highlighted the ESA guideline regarding the use of quantitative neuromuscular monitoring and the more detailed guidelines by the ASA with respect of the use of neuromuscular monitoring devices. The European Society of Anesthesiology and Intensive Care clearly states that we recommend the use of ulnar nerve stimulation and quantitative neuromuscular monitoring at the adductor pollicis muscle to exclude paralysis. And that's clearly based on data. There are 7 randomized clinical trials in almost 787 patients who show in combination a risk reduction by 20% when using quantitative neuromuscular monitoring compared to qualitative neuromuscular monitoring or no neuromuscular monitoring, with the endpoint of a TOF ratio below 0.9 when the patient received the recovery room. That means a clear risk reduction by using quantitative neuromuscular monitoring to reduce residual block. The key manuscript that has shown this effect is done by Murphy and colleagues more than 15 years ago, in which they showed that the use of accelerometry compared to tactile monitoring results in a group of patients with quantitative monitoring that is almost in any case with a TOF ratio over 90%, while patients that have been monitored with a qualitative device in almost the half of the cohort had a TOF ratio below 0.9 when arriving the recovery room. And this was not only a measurement by a TOF ratio that has also consequences on the patient conditions. So those with the tactile, the peripheral nerve stimulator monitoring arrived during the transport episodes of oxygen saturation below 90% in 21% of cases. And they needed airway maneuvers in order to stabilize the situation. And even at the PACU, the same amount of patients, again 21%, had drops of oxygen saturation below 90% in the PNS, in the tactile monitoring group. Let's go to the practice guidelines by the American Society of Anesthesiologists. They had shown in more detail, or their recommendations are more detailed. The first point is clinical assessment is insensitive to avoid residual neuromuscular block. The second is quantitative neuromuscular monitoring is superior to qualitative neuromuscular monitoring to avoid residual neuromuscular block, as shown by the Murphy study in the slide before. The third recommendation is that a TOF ratio must be greater or even than 0.9 before extubation. I will show you that I think this is very conservative. I think we should have a higher amount of TOF ratio in one of my next slides. Very important, they recommend measurement at the adductor pollicis muscle for quantitative neuromuscular monitoring. And first of all, they say it's misleading to do neuromuscular monitoring at the eye muscles. It's very simple. The reason for that, the eye muscles have two different muscle types that have different sensitivities to neuromuscular blocking agents. And it's not clear when you mount such a neuromuscular monitoring to the eye muscles, which muscle you are measuring, and therefore you may be misleaded by the results. So let's come to the first recommendation, why clinical assessment is insensitive to avoid residual block. This is a slide we have published just 2 years ago, and it makes clear why clinical signs do not provide sufficient information regarding complete neuromuscular recovery. On the x-axis, you can see the TOF ratio as measured at the hand muscles. On the y-axis, you see the function of the qualities shown in that slide. And at the end of anesthesia, or when the patient is extubated, we of course expect that all these functions have reached 100% of the effect measured before anesthesia, measured before given neuromuscular blocking agents. So when you are guiding your decision to extubate the patient with a tidal volume as measured and in the intubated patient, then it's clear that this must be a harm for the patients, because a TOF ratio of 0.2 that guarantees 100% tidal volume results in a 0% function of swallowing, hypopharynx muscle, clenching teeth, and no normal vision. And you can see that even hand grip is earlier recovered than the very important swallowing function, and head lift and functional forced vital capacity also. So only the quantitative measurement of the TOF ratio guarantees, and it's over 0.9 or maybe higher, a 100% recovery of the important muscle functions in the patient. And these functions can't be clinically identified with the patient, with an intubated patient or an anesthetized patient. So you must wait until the patient is awake, and if you don't have measured it, it can happen that the patient can't do that. So why 0.9? This is related to Eva Sundman's study published in 2000, and what they showed is that volunteers receiving neuromuscular blocking agents to reduce the TOF ratio step by step down to 0.6 have a risk of microaspirations. And surprisingly, they decided that 0.9 should be sufficient. But there is even at 0.9 a significant difference regarding the microaspirations compared to control measurement. And it was Matthias Eickermann some years later who explained the risk for that. The hypopharynx muscles are impaired even at levels over 0.9, and so they said in following that study that 0.9, it is not sufficient enough to guarantee a complete recovered swallowing function, and recommended to aim for TOF ratios as high as possible. And we were in this prospective observational study, the popular study, able to support this data by the Eickermann group, because we could not find significant effects until a TOF ratio of 0.95 is exceeded. TOF ratios of 0.9 were not sufficient to have a situation without or with a lower risk of postoperative complications. Here you can see at 0.9 the recommended level of recovery, even by the most recent recommendations by the ASA, did not show a significant difference in postoperative pulmonary complications, but it should be higher. The question now is, which kind of neuromuscular monitoring shall be used? And Mohamed Naguib has published, together with an expert group in 2018, a consensus statement about every case of neuromuscular monitoring. And even when I will tell you it's better to use a neuromuscular monitoring, whatever you have, a quantitative monitoring, there is clear an advantage to use electromyography. And that's related to the fact that EMG is not affected by changes in muscle contractility like temperature, pH, like positioning. Preload is not needed, and immobilization of the hand is also not necessary. So this is most of all an advantage of this technique of the electromyography compared with other techniques. So this is the most recommended technique, but if you don't have it, it's better to use the quantitative technique that is available in your hospital. Another recommendation done by ESA will lead us to one of the major topics of my talk, the need for deep neuromuscular block in order to improve surgical conditions. What's a deep block? A deep block is a situation in which the TOF count is 0 and the post-tetanic count is about 1 or 2. It's not an intense block without any reaction, even not to post-tetanic stimulation, but with a TOF count of 0. A moderate block is a TOF count between 1 and 3, and neuromuscular recovery starts when a TOF ratio can be measured. That means a TOF count of 4, but a TOF ratio still below 0.9, it's a level of which we would like to allow extubation. So, is deep block really necessary? The recommendation clearly states that there are situations in which a deep block may help and surgeons do better their job. I think this is most likely true, but the risk of this recommendation is that the use of deep block will be increasingly familiar, will be increasingly used, and this is not without risk. Some questions, some pictures about if it's really so very frequent and it's really throughout the whole surgery necessary. This is the manuscript by Martini and the Netherlands group who compared moderate block versus deep block for laparoscopic surgery. And you can see what the authors have concluded. With deep block, you have no situations with a score of 0, unacceptable conditions, 2, poor conditions, and only few situations with acceptable surgical conditions, but mostly they are well or excellent. With a moderate block, you have some situations in which the conditions are quoted by the surgeon as unacceptable or at least poor. But importantly, which were the situations? It were the situations during insufflation of the pneumoperitoneum. That means some patients fought against insufflation in a very early state, but the rest of the 1 hour, they did not have any problem. And some situations were during the extraction of the gallbladder. It's a very late period of the surgical procedure. So it was not necessary throughout the whole surgical procedure. And this goes through the literature in almost 5, 6, 7 years, and Park and colleagues published a systematic review and meta-analysis about the need of deep block during laparoscopic surgery. And what they found is that surgery is a little bit faster with deep block, and deep block was associated with excellent or good surgical rating more frequently, but not always, than moderate block. And it was only seen when multiple assessments were taken. There was no difference when the assessment was made only on one occasion. And finally, the trial sequential analysis suggested that due to only small trials with high heterogeneity, finally no conclusion can be drawn. And in this context, I think it's very important that one of the oops, it seems not to step forward. Let's see what happens here. It's very important to show you this manuscript. It was again from Martini's group. I have added in the quote of that study Martini's name because it was the same group who did the study which I showed you as the first study in that queue. Again, does deep block improve conditions for laparoscopic, in this case, renal surgery? And what they compared was, again, during the time course, every 15 minutes, they ask the surgeon about the conditions. And what you can see here, there is no difference between the blue group, moderate block, and the red group, deep block. And even the situations with more or less not super perfect conditions were so low that there was no relevant effect of deep block compared to moderate block when sevoflurane has been used for anesthesia. So, taking into account the risk of deep block in my next slides, I think it's important to summarize that surgical conditions and treatment recommendations should be really related to the surgical situation. With other words, if a surgeon really doesn't have so big problems that he's told you that the conditions are not acceptable, then of course you must give an increment. And by the way, I don't think it's important what kind of block in such a situation is. It's an attempt to improve it. But in situation with acceptable conditions, why should you go for a deep block if the surgeon is almost happy or even in good surgical conditions? So I think the depth of block should really be adapted to the surgical needs, and there should be no deep block throughout the whole surgery. And that's clearly why recurrence of block was reported very frequently in the United States the last years, since sugammadex was available and since it was possible to reverse neuromuscular blocks, even deep neuromuscular blocks, very fast. The history of recurarisation, or the history of recurrence of block, is started with the introduction of tubocurarine in the 1950s. But in that time, reappearance was about 3, 4, 5 hours later after surgery, and this was most likely related to a renal failure in these patients. The measure taken at the time was the dose was reduced, neostic mean or periodostic mean was introduced into the clinical routine, measures were taken to improve and use neuromuscular monitoring. In that time, it was first of all qualitative monitoring, and even more important, these long-acting drugs were changed to atracurium, vecuronium, vecuronium, medium-acting or short-acting drugs for neuromuscular blockade. So after this development in the 1980s and 1990s, only case reports about recurrence of blocks have been reported, and they were mostly related to a neuromuscular disease. With the invent of sugammadex, however, a new phenomenon of recurrence of block appeared. And the big difference to these former cases was that this recurrence of blocks happened relatively short after extubation, and in most cases also a complete neuromuscular monitoring and reversal with sugammadex has been done. This phenomenon was explained by Elevet and colleagues who had seen one of the first recurarizations or risk of rebounds in a dose-finding study. And their explanation was that deep blocks antagonized related to high doses of neuromuscular blocking agents. And first of all, if there are the drugs of long duration of action have a risk that a block that started to recover will have a rebound. And here you can see the dose relation to the dose of sugammadex given in that study at a deep block PTC1-2. And you see, related to the given dose, you see something like a slow recovery, not really a rebound, but within the area in which, using quantitative neuromuscular monitoring, everybody should see that there's going something wrong. But also this kind of rebound after complete recovery to a TOF ratio of 1, a rebound in which the patient most likely is not anymore in the operating theater, is a PACU or even at the ward. And the risk is increased in perfect renal function, because when sugammadex is excreted and the neuromuscular block is redistributed from the fat, then the risk is even higher. Quite the opposite what has been seen in the early cases in the 50s, 60s, and 70s. The low hepatic clearance of rocuronium is another factor in cases in that this is the case. And yes, in neostigmine it can also be seen, but neostigmine will most likely not used in cases with deep block. I will illustrate these findings by the next slides. Normally, we see neuromuscular block with this TOF ratio only when the TOF ratio is between 0 and 1. The margin of safety, that is the amount of acetylcholine receptors that has to be blocked before any drop in TOF can be seen. But over a margin of block, further blockade is out of the option to observe, to see it in the TOF ratio. And importantly, when the TOF ratio is completely recovered, there is still a high amount of receptors blocked by the neuromuscular blocking agents. This is a 100% response to TOF, which is seen when the number of block is below the margin of safety. And that doesn't step forward. And this is the area of no response, the area of no response, in which changes in the block can't be seen because the TOF ratio is not sensitive enough. Obviously, I'm not able to advance the slides. Sorry for that. Okay. So you see here again, no response to TOF stimulation. You will not see differences in blocked acetylcholine. So the first scenario of a rebound of block during deep and moderate block. If there is a rebound in the area of no response, the change in the receptors is here. And what anesthesiologists with the quantitative neuromuscular monitoring will see is a rebound phenomenon in the area in which no response can be seen. does not really result in a rebound phenomenon that can be seen by neuromuscular monitoring. This very frequent happens in elderly patients, and the simple result for the clinical routine is that they recover slower than expected. If the slide goes further, you can see that this is increased with a higher risk of, here it is, with a higher risk of recurarisation. But first of all, the result of this kind of rebound related more to physical differences in the redistribution area is more likely to have a slow recovery, but not the typical pattern of a rebound phenomenon. The next slide should show what happens when a rebound happens during the recovery. That means in the time in which the TOF ratio is between 10 and 90, but not over 90. This slide normally should show you now that this is a rebound that happens during recovery, but with a low risk of being overlooked, at least when you are using quantitative neuromuscular monitoring. When the neuromuscular block recovered up to 100%, that means that the number of blocked acetylcholine receptors is below the margin of safety. And in the early period here, it can happen that due to redistribution phenomena, the amount of blocked receptors again increases. And then you have this rebound after a recovery before. And this is well known as recurarisation, and that happens almost in cases in which too much rocuronium has been given. Some examples of that. Here a case of an obese lady from our own department in which the ideal body weight was based for dosing sugammadex. With other words, the dose of sugammadex was too low. You can see here at a TOF count of 2, the dose of sugammadex has been given. You have a complete recovery to a TOF ratio of 100%, but very early it comes to a drop, not below 90%, but then after a period of about 10 minutes, the TOF ratio goes down. This is T1, but recovers spontaneously within the next hour. A typical case of a rebound with clinical consequences, as a complete recovery has been seen and a relevant rebound, most likely resulting in recurarisation symptoms if the patients would have extubated. That was not the case in this patient. Another case, recurrent colleagues, a female patient, 45 years of age, 150 kilograms of body weight, a BMI of 48, a very obese patient. There was a laparoscopic fascia repair. Rocuronium was given in excessive doses for that surgery, and the last increment has been given 40 minutes before extubation. The TOF count was 2 when sugammadex of 200 milligrams have been applied. According to actual body weight, 1.7, according to ideal body weight, 3.7 milligrams, so more or less a sufficient dose according to the recommendations at TOF count of 2. But remember the excessive dose of rocuronium. What happened was complete recovery between 5 minutes after sugammadex. The patient was extubated and was transported to the PACU, where apnoea and flaccid paralysis appeared, and the measurement of the TOF count that was immediately done showed again a TOF count of 2. And another dose of sugammadex was necessary to have the patient recovered within 3 minutes, and the TOF ratio was again over 0.9. Sufficient breathing, no weakness. So this is a excellent case showing recurarisation or rebound after complete recovery with too low the dose of sugammadex in this very critical area. Another case, I would like to focus you on the magnesium application that has been given to that patient 2 times. Rocuronium was infused over many, many hours for a TOF count of 0. This patient had about half an hour later, again, a problem with a flaccid paralysis, most likely due to the co-effect of magnesium. Another critical example of a recurarisation. Here, very frequent in children, a case, 2 days of age, 3.65 kilograms of weight. This child became 7 milligrams of rocuronium and a dose of 15 milligrams of sugammadex. 7 milligrams of rocuronium, that means 2 milligrams per kilogram. That's 5 to 6 in that age, most likely 7 ED95s. What happens after extubation? The child got a ventilatory problem, needed another sugammadex in order to overcome the recurarisation of block. A 3-week-old child, 4.1 kilograms. That child received 4, 8, 10, 11 milligrams of rocuronium. That's about 8, 9, maybe 10 ED95s, an excessive overdose. And again, it was not enough to give this child 36 milligrams of sugammadex. The child was not extubated. It was necessary to wait until they did no neuromuscular monitoring until it was able to extubate. This 5-month-old child with 7.3 kilograms of weight received 20 milligrams. It's again a dose of about 10, 11 ED95s. Extubation after sugammadex, much too low the dose for such excessive doses. Ventilatory event, another sugammadex, and the problem was resolved. Let's go this because we lost some time. The question now is, how can we avoid such recurisations? The first point is you have to do quantitative neuromuscular monitoring. And as I have shown you in one of my first slides, about 15% in Europe are using quantitative neuromuscular monitoring. Also, this technique is available for the clinicians for more than 30 years, but still 15% are only using quantitative neuromuscular monitoring. But this is similar to the BIS and the entropy, the monitoring of hypnosis. Again, a very low rate of about 5% receive this kind of monitoring of anesthesia. Also, it's more than 25 years available in the market. We all know from the innovation adoption curve first published by Rogers that the critical amount between those who are interested in such innovations and the huge majority, or as you know, called it the chasm, is related or can happen if many things bring innovation to the providers, to the users, and the question we are now asking as the guidelines have been published, are these guidelines an option to pass to cross suggestion? Are these guidelines a guarantee for routine monitoring of anesthesia? Most likely, there must be more than guidelines. One of the most likely necessary things is education, or what's necessary is algorithms that include monitoring devices, that include drugs, and that include medical equipment in order to overcome the not using of innovative techniques. But the other point is people must have any monitoring devices, irrespectively what kind of monitoring they are using. Those who do not have it are not able to use it. And that it is possible to improve the use of monitoring devices when monitors are available has been recently shown by Weigel and colleagues 2 years ago. They sold quantitative monitoring devices and provided these techniques to all their physicians and anesthetic nurses, and step by step, the use of neuromuscular monitoring was increased. And not surprising, the use of an effective reversal drug was increased, but also the number of cases that obviously do not need a reversal agent increased, and the very ineffective drug neostigmine has been used not anymore, or in a significantly lower number. So we have written about that in our pro-can debate, also published in 22. And we think the combination of making neuromuscular monitors available, plus teaching, plus algorithms, how to use monitoring and how to use reversal agents, will be the most important approach in order to improve its use, and also in order to make complications and also recurisations less frequent. Anytime a neuromuscular blocking agent is administered, neuromuscular monitoring must be used to guide administration. That was one of our statements, and to ensure adequate reversal of neuromuscular blockade. We feel that adequate reversal of neuromuscular block is defined as a TOF ratio greater than 0.95 measured at the adductor pollicis. A higher level is also even better than a level of 0.9, because then the risk of recurization is most likely higher than when you're at least for 3, 4, 5 measurements over 0.95. A peripheral nerve stimulator can't confirm a complete neuromuscular recovery indicated by a TOF ratio over 0.95. And in agreement with the guideline writers, clinical signs are unreliable and must not be used to confirm adequate neuromuscular recovery. And it's important that people know about we are speaking. That means what's a profound, what's a deep, what's a moderate, what's a shallow block, and the terminology must be used in the same way by all providers. How to avoid residual block? Jennifer Hunter and myself have recently written our ideas how to avoid that. And the first thing is, there is neither need nor it is really useful to have deep block as a routine. Do not use excessive doses of rocuronium, even for rapid sequence induction. Doses of 3E95 should be enough. always use quantitative neuromuscular monitoring and take care that if the block goes down after recovery, that you most likely have to given a too low the dose of sugammadex. Even when you have given the recommended dose, first of all, when the sum dose of rocuronium exceeds doses over 4 ED95s. That means at least over 1.2, 1.5, 1.6 milligrams per kilogram. It's very important to have to think that maintenance over a deep block over a time more than an hour increases the risk of recurarisation. And finally, avoid polypharmacy. Most of all, magnesium is one of the candidates that potentiate neuromuscular block. And if necessary, and if there was a need to do that, then continue quantitative neuromuscular monitoring for at least 5 to 10 minutes after you have reached a TOF ratio over 0.9 in order to see that this was not a single event, but a stable and reliable neuromuscular recovery. So, and actually these last slide from my side, when you're doing anesthesia for neonates and infants, it's very important that you have always to label the drug syringes. It's important to have noted the dilution of the drugs and do the calculations and correct it or consider to double check the dose with another clinicians. The cases of too high the doses of rocuronium were significant in the literature. Always use quantitative neuromuscular monitoring with the approved infant sensors, but most of them are only approved for infants over an age of 28 days or over an age of 5 kilograms. It's Geneva Hunters and we are absolutely clear that it's better to use this not approved sensors in the smaller ones, because it's better to have anything than to have nothing, and that would be the given alternative. And it's the same item if you're going to have deep blocks or you have residual blocks in infants and neonates. Sugammadex is not approved for that, but speaking with many pediatric anesthesiologists, we all think it's no solution to wait or to have the patients with a residual block or the infants and neonates. It's most likely the one and only approach to treat the infants and neonates on the best clinical level. So I thank you very much, and I thank GERS again for giving me the opportunity to give that talk. And I'm so sorry that the technique had some problems. Obviously, the line between my office and the center was broken. Thank you very much.
Thank you so much. And yes, we, much like treating patients, sometimes things are a little unpredictable sometimes. So I appreciate everyone rolling with the challenges we had today. Thank you for finishing with some pediatric information. As a peds intensivist, I can validate what you're saying. I think that I've taken many patients back who've required some sugammadex in particular. I've seen a lot here in the US. So appreciate your words about the peds population. We have a few questions to go through here. I know we're close to the end of our time. I want to get through at least a few of these. For those of you who can stick around, please do. If you need to leave, we're going to record this conversation, so feel free to come back to it and find the Q&A here at the end. The first question that we had, I feel like you spoke a little bit about here at the end, but I want to make sure we cover the question. It said, we definitely need to avoid recurisation by changing clinical practice and leveraging quantitative monitoring. However, is there still risk of residual paralysis or recurisation postoperatively? And what is your best way to identify it as early as possible? I think, when is the right time?
Yeah, I think the first and most important point is that you should not stop neuromuscular monitoring. Sorry. You should not stop neuromuscular monitoring in the moment you have achieved the first 0.9 level. I very frequently see in routine that people stop neuromuscular monitoring with the first level of TOF over 0.9. Also, they have a time of 15 or 20 or 30 minutes until the patient can be extubated. So you will see recurisations in most cases within the first 15 minutes after TOF ratio of 0.5 or 0.9 has been reached. So continue monitoring until the patient is extubated. The other point is, of course, in the PACU or in the recovery room, you had to take care of patients. And as with these fast-acting drugs, with this fast-acting reversal agent, and with a medium-acting rocuronium, from a pharmacokinetical point of view, I do not expect recoveries after an hour. So clinical care in the PACU and the recovery room should be always done, at least when high doses of rocuronium have been reversed.
Excellent. One other question about monitoring specifically, and then there are a couple of questions about reversal. The question is, what role do electrodes play in EMG monitoring? And can you recommend EMG monitoring for robotic and cardiac surgery? Are there other areas of application for EMG, or is it preferable to AMG for every operation?
EMG is primarily EMG monitoring is the most stable way to do neuromuscular monitoring. One major problem is that with the current techniques, there may be a problem with the application of the electrodes, and it's a source of mistakes. So cardiac anesthesia, it's, most likely in these patients where you have a long duration of clinical recovery due to temperature and so on and so on, it doesn't make the big difference.
Great, thank you. Moving into a question about reversal here. So there are now cheap sugammadex generics. Now you can maintain complete neuromuscular blockade throughout the entire operation and antagonize it inexpensively with the help of generics when anesthesia has ended. To what extent can NMT monitoring be justified, especially with disposable sensors?
So I think it becomes clear that when sugammadex became generic, obviously people are giving more rocuronium. And so at the end of surgery, you don't know where you are. So it's not a good idea to give sugammadex without control. There is a at least 15 years old study by Kotake from Japan, who gave sugammadex to patients without neuromuscular monitoring, and the incidence of residual block in the recovery room was about 8%. So with other words, using sugammadex without neuromuscular monitoring doesn't avoid residual block. The question is how much sugammadex you will give. If you give, again, if there has been given much more rocuronium than usually recommended, if you have given deep block for a long time, you most likely should have the generic sugammadex available, and most likely you should give more doses in order to avoid some higher doses, maybe repetitive doses of sugammadex to avoid recurarisation. That's, I think, the best reaction to the cheaper sugammadex, not to avoid neuromuscular monitoring.
There were two questions here as well about specific mechanisms, so we're going to get a little bit of science here. But one of them was, does sugammadex in the elderly have any effect on heart rate compared to younger patients? So are you seeing adverse effects related to sugammadex in elderly patients, on the opposite end of the spectrum of where we ended?
In which patients? Sorry.
Elderly, so older patients.
Yeah. So elderly patients most likely needs the same dose of sugammadex than youngers. There is not the big difference. As mentioned in one of my educational slides, I think that redistribution phenomena in the elderly are more likely. So you will see a slower recovery in the elderly, and therefore the risk is a little bit higher than in younger ones. So if you see with quantitative neuromuscular monitoring a slower recovery after the sugammadex, I think there are two clear consequences. Maybe you give another dose of sugammadex, maybe first of all you proceed with the neuromuscular monitoring. That's the best reaction for such observations in elderly. Regarding complications by sugammadex, I think elderlies are not at a higher risk by sugammadex itself than others. Or finally, I do not see it.
Great. And then one other question specifically about sugammadex that was asked about the mechanism, the magnesium, interaction with magnesium that extends the relaxant. Does magnesium affect the muscle directly, or is it antagonizing the sugammadex directly?
There's no interaction between sugammadex and magnesium. Magnesium itself paralyzes muscles by an independent effect on simply by the magnesium effect on the neuromuscular stability, on the stability of the muscle membrane. The point in terms of pharmacokinetics is that magnesium reduces the margin of safety. So you need lower doses of rocuronium in order to see a block. So actually you have to reverse not only the sugammadex, which is responsible for a block, but also you have to reverse the sugammadex, which normally would not have a clinical effect, the rocuronium that normally would not have a clinical effect. So simply increasing the sugammadex dose resolves the problem. The molecular weight of sugammadex is 4 times higher than that of rocuronium. If you give magnesium, I would say if you give 50 milligrams rocuronium, you have to give 200 milligrams sugammadex. If you have given 100 milligrams rocuronium, you should give 400 milligrams sugammadex in order to completely bind the rocuronium, as magnesium itself has a paralyzing effect. If you give magnesium without any neuromuscular blocking drug, you can also see a drop in TOF. But when when all paralyzing drugs are out, all rocuronium or whatever is extracted from the patient, then it's simply the magnesium effect that can't be resolved by sugammadex or whatever.
Excellent. Well, I really appreciate your time. I appreciate you going over a few minutes here just to answer some of these questions. Great questions from the audience today. Appreciate your engagement. So unless you had any other final thoughts, our webcast is coming to a close. Thank you all for your time and attention.